Hello guys, this is Jonathan Munoz and today we're going to start what I call the Finding Your Angle video series to help you to give you 5 domains on hospital medicine, inpatient medicine, and in general primary care medicine. 5 domains that catch a lot of attention and are big cornerstones of what medical care should be um, based on. So, we're going to talk about 5 different topics, and once you understand each of these topics, you should be able to create your own personal statement with an idea of talking about that interest of yours. Or you should be able to do a rotation or an observership rotation demonstrating knowledge on these areas. Also, it will help you to perform well in your interviews. Why? Because the interviews are part of that. We want to see what do you know about the American healthcare system that doesn't come in books. Okay, so the topics are going to be underserved work, palliative care, antibiotic stewardship, clinical documentation improvement, and chronic condition management, which includes diabetes, hypertension, CAD, CHF, COPD. So on each video, we'll talk about these topics, and you will have to, with this initial information, you will be able to read more, to have good conversations with people about this. Okay, so today we're going to start with underserved work. What is underserved work? Why is it important for primary care medicine, family practice, internal medicine, pediatrics? Why? Because regardless of where you go for training for residency, the more likely situation that you're going to face is that you are working in an area of need, in an area that has a mixed population of people that have money or a stable, steady income, and people that have very low income or no income at all, or survives in governmental support. So, regardless of where you go to do your rotations, even if it's the best location, the location with the highest income population, you will still face that there are locations within that area that your hospital will serve that have people with low income. And with this low income comes to the immigration population or the immigrants population. You will see patients that don't have medical insurance. Where will you see them? If your clinic or your hospital only takes patients with insurance, where will you see them? Well, usually internal medicine and family practice residents have rotations in peripheral clinics that take care of patients without insurance. These are the free clinics. Not only rotations, but they also send you there for to start the year with physical exams, with helping them, or these volunteering vaccination clinics. So you will be exposed to this for sure. Now, the concept of underserved work, what is underserved work that is important? Why is it catching so much attention? And pay attention to this part. Underserved work, underserved medicine, and social determinants of health. Social. What is the social? What are the social determinants of health? For example, for me, that I have, let's say I have diabetes and hypertension, and I don't have an income, then I'm not going to be able to pay for the medications that I should be taking. I will be able to get some medications that are free or are very low cost, $5, but I won't be able to get an insulin pen if the insulin pen costs $100 a month. Because with the little money that I have, I prefer to pay for food for my kids or to study instead of paying for my medicine. The other one is maybe I don't have a car. Let's say I don't have a car. By not having a car, I cannot access or I cannot go to my medical appointments, or I cannot go to work in time, and I sometimes will be going from job to job. Why? Because I cannot make it in time, and the owners will be firing me all the time because I'm not a reliable worker. The other one is medical literacy, or in general literacy. How is this person, Jonathan? How is he uh, able? Is he able to understand or even assimilate any of the information I'm giving him in this medical appointment? I'm telling him that his diabetes is getting worse and worse. His hemoglobin A1C is 13 from 7. Does he understand the concept of what's happening from a hemoglobin A1C that went from 7 to 13? And why I want to put him on insulin rather than keeping him on metformin? So if he doesn't understand, and I'm not recognizing that need, that I need him to understand this, maybe by reaching out to family members, maybe by reaching out to someone that he trusts, like for example a pastor in a church that he attends. How is he going to take care of his health if he doesn't understand the basics? So that's literacy, not only medical literacy, but literacy in general. And the last one could be if I'm a victim of abuse, another social determinant. Am I a victim of abuse? And because of this abuse, I am financially abused, emotionally abused, and because of these reasons, I'm not able to look out for myself, to look out for help. So the first time that a medical provider, doctor, nurses have an opportunity to meet a patient, as part of the social history, you have to try to also find out these little pieces of information. You don't have to find out all of them, but you at least try to ask for 4 or 5 by saying, do you have a car? Do you have a stable job? Do you have a steady income? Do you have food in your house every day? Are you able to take your medications? Do you understand this? And you're not going to go through all the social determinants of health because there are so many domains. But what you can do is you can also say in the interview process, saying, is there something else that you think could be a barrier for you to achieve good health? Or put it in different words, but basically the idea is there another thing that you think could be a barrier for you? It could be different things. It could be drug use, could be depression, it could be trauma from childhood, religious beliefs. Okay, so now we're getting more and more social determinants of health, underserved work. Why? Because these are all hand to hand, right? They go hand by hand. And then who are these people that you will have to look out for to try to nag into these social determinants of health? We're talking about the community or the patients that are considered to be vulnerable populations, mainly, and I say mainly, why? Because even a person that apparently seems to have a steady job, a steady income, may have other social determinants of health that be altered, like trauma from childhood, lack of self-confidence, lack of support, lack of understanding, because you can make a lot of money and still have a very little understanding or literacy or medical literacy. But in general, we're talking about vulnerable populations, and these vulnerable populations include disabled patients, the chronically ill. I'm not talking a patient that has diabetes for 10, 15 years. I'm talking about those very, very ill patients that not only have diabetes, hypertension, CAD, CHF, COPD, they are oxygen dependent, they are on a wheelchair-bound situation, and they are constant users of medical care, not only on their primary care provider's office, but in the emergency department. So the LGBTQ community and the very young and the very old. So these are considered vulnerable populations. And, and so underserved work is not only the idea, when we talk about underserved work, guys, it's not just the idea of, oh, I'm willing to go work in the poorest area of the country. No. Underserved work means that you understand what is the cause or what is the root of the problem in people that live in underserved communities, in underserved situations. Who are these people that are part of this frame, not just the underserved by being poor and living in a poor area, but people that have or are affected by social determinants of health that are not necessarily linked to poverty. So underserved work, that's the beginning. The other part is, and now that we talk about how can we put this in context? How can we say for your rotations? Let's say you are in a rotation on observership for internal medicine, and you have the patient that has just now been admitted for an STEMI, had a cardiac catheterization with a stent placed. As part of his medical problems, he has uncontrolled diabetes and hypertension. So when you present this patient, when the patient is ready to be discharged after having his stent placed, and there is a prescription for, usually what we're using these days is Brilinta, aspirin, and we try to correct whatever is next to it, like diabetes and hypertension, right? So you will be giving this patient a whole prescription with these 5-6 new medications. Most of them will be able to be covered by free clinics, be given for free. But some of them, like for example, Brilinta, has a very high cost these days. And if you just give this patient this prescription and the patient say, oh, okay, I will buy it, I will find a way to buy it. But it costs $400 out of pocket and he cannot buy it. So this stent is very likely to be clogged again. So if you were able to have a heart-to-heart conversation with the patient before giving the prescription, like saying, hey, so these are the prescriptions, do you think you have enough money to cover for this one here, which seems to be very expensive out there? And he says, in all honesty, doc, I don't think I have enough money to pay more than $50 in total a month. And you then you say, oh, okay, let me see what alternatives we have. And usually when a patient cannot pay for Brilinta, we use Plavix. It's not the best situation, but it's better than not taking dual antiplatelet therapy. So the change is made, and now the patient is able to comply with the medication. So you present this case and say, doc, we are about to send this patient to home. There's this medication list, but the patient is not able to cover for all these medications. We discussed the possibility of changing Brilinta to Plavix, and the doctor said, hey, that's a great idea, do that, because at least he will get dual antiplatelet therapy that way. And so you created a good impression on this attending because you investigate more about your patient's living conditions. How is this medication going to influence his ability to sustain his family, his ability to get food, while at the same time taking care of his health? Okay, let's say we did that in rotations. Now, how are you going to apply this to a personal statement? So the new changes are coming in the lines that personal statements should not be telling you are smart, you are intelligent, you are kind, compassionate, you are a hard worker. No, you should be telling a story that shows in that story that you are smart, compassionate, all those good things. And should not be dramatic, but should be something real. And should be realistic and real. So for example, in the same scenario, let's say you're mentioning this patient with the STEMI. Everyone knows that the first person that diagnosed the STEMI is not the internal medicine resident on his first year, but it is the emergency medicine doctor who is the first one that gets an EKG, or is the paramedic that brought the patient that did an EKG in the ambulance. So by the time that the patient arrives to most hospitals in the United States, a diagnosis of a STEMI is already made. The process of getting a stent is already made. And you can relate the whole story of the STEMI, but the important thing that you have to mention here in this story is, at the end of this patient's hospitalization, my interest was to investigate more of his living conditions and if he will be able to afford these medications. So we discussed different factors that may be influencing his health, and he was not able to afford these medications. We discussed these changes, possible changes on medications with cardiology, and changes were made with more affordable medications that are still effective. And the patient was able to obtain his whole amount of medications. I felt that this was a good opportunity to highlight the importance of open communication on the doctor's-patient relationship in order to defeat any possible barrier to achieve a good outcome. Use these words if you want. Huh? So that's kind of what you should do on a personal statement line, an opening if you want, mentioning that you are into working with underserved communities, and how this is social determinants of health investigation. Because you don't have to say social determinants of health as a whole word, but it comes out in this example. Why it comes out? For a medical director, social determinants of health is a big topic in medicine these days. We talk about this all the time. We talk about how can we teach the students more about social determinants of health, and how can they really use it? How can we do research on this? How can we take these students that are doing cardiac research into doing social determinants of health research? And it's hard, but it's kind of the goal. It's very much the idea of what medicine is turning into. All right, guys. And for the interviews, you can just talk about the same, and it will be noticeable. So this is the beginning. This will help you a lot on rotations, personal statements, and definitely during your interviews if you get an interview. So good luck, and stay tuned for the next video.